Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Germany, Dr. Benny Kolbel. He is a surgeon at the Military Medical Center at Ulm in Germany, and is passionate about surgery, emergency medicine, teaching, and research. He has published articles with regard to trauma surgery, and he, along with Professor Sandro Craig, has embarked on a very novel research pertaining to traumatic brain injury. And we're extremely honored to have him today at our webinars, and today he'll be talking about decompressive laparotomy in traumatic brain injury. The speaker for the second session of today is our honored guest from China, Dr. Jiang Haihui. Dr. Jiang is an executive director of the Hospital Specialty Clinic Building Branch of the China Geriatric Healthcare Association. He is also a full member of the American Honor Society of Scientific Research. His research interests are focused on the molecular diagnosis and precision treatment of brain gliomas. He has authored more than 20 papers as a first author or corresponding author in famous journals like Cellular and Molecular Immunology, Neuro-Oncology, and JNS. We are extremely honored to have him today at our webinars, and today we'll be talking about molecular biomarkers based surgery for gliomas. The chair for the first session of today's webinar is our honorable guest from Colombia, Prof. Andres Rubiano. Prof. Rubiano is a professor of neurosciences and neurosurgery at the Elborz University, Bogota, Colombia, and chair of neurological surgery service at the Valle Salud Clinical Network, Cali, Colombia. He is the president of the Neurotraumatology Division of the WFNS. He was the past president of the Colombian Association of Neurosurgery and past president of Neurotraumatology and Intensive Care Chapter of the FLANC. He is chair of the International Committee of Neurotrauma and Critical Care Section, American Association of Neurological Sciences, and he is the international director of the Brain Tumor Foundation USA and vice president of the Global Neuro Foundation, Switzerland. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable guest from Pakistan, Dr. Shahzad Shamim. Prof. Shamim is an associate professor of neurosurgery and chief of services for neurosurgery, neurology, and psychiatry at the Aga Khan University, Karachi. Dr. Shamim is the inaugural director of the Surgical Neuro-Oncology Fellowship Program and Dean's Clinical Research Fellowship Program, as well as former Internship Program Director. He completed an ACNS Visiting Surgeon Fellowship at Henry Ford in USA and later went on to complete a fellowship in spine surgery in neurology and neurosurgery at the Queen's Squares, UK. He was awarded the Excellence in Teaching Award by the Department of Surgery at the Aga Khan University. And he has authored around 200 manuscripts, abstracts, book chapter. He is also on the editorial board of 5 journals and reviews more than 20 journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I'd like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Prof. Andres Rubiano.
Thank you for the kind invitation. I think this is a very important topic. I'm going to share just a couple of slides in order to introduce the session. So we are going to hear excellent talk related to decompressive laparotomy TBI. This topic has been discussed over a while in some specific general trauma meetings. These are the classical discussions of this condition. It was initially described in 2004 in an article of a case discussion from the group of the Shock Trauma Center in Maryland. And then Professor Thomas Escalea from the same center discussed the interactions between the increase in intra-abdominal, intrathoracic, and intracranial pressure. So this has been a topic that has been discussed in a while. And I just remember in the INTS 2022 Berlin when the study was presented and they were officially starting the process for this study that are going to be discussing. There have been some systematic reviews, mostly for small cases, groups regarding this specific topic. And the protocol for the study was published in 2023 in Brain and Spine. So we have the pleasure now of hear from Dr. Benny Kolbel the aspects related to this important study. So this is just to give the introduction to Dr. Kolbel in order to hear this important topic. Thank you so much.
Dear Professor Rubiano, thank you very much for the kind invitation and introduction to the topic. Professor Krishnakutty, Professor Shamin, thank you very much for giving me the opportunity to present in this webinar our research project. As you already introduced the topic, we did start a project on decompressive laparotomy for patients with severe traumatic brain injuries. But let me start with the path, how we came up with this research idea. I have nothing to disclose other than that I'm not a neurosurgeon. I'm a general surgeon and I do some trauma surgery back home in Germany. And this is not my home base, but we developed this together with our neurosurgical friends in order to benefit those patients. This is the place where I'm working. It's a middle-sized German level 1 trauma center. We do elective surgery, we do trauma surgery, but we do not have massive amounts of traumatic brain injuries. We usually have like one major trauma activation at a time, but usually we are not overwhelmed with multiple traumatic brain injuries at a time, which can be different in other parts of the world. As we know, low and middle income countries have a much bigger burden of disease if it comes to traumatic brain injuries. And as we know, the mortality is quite high in those countries. This is the data and evidence to this, but I really got a feel for this pandemic of traumatic brain injuries in low and middle income countries while I was doing my trauma fellowship in South Africa. I did this fellowship in the Chris Hanneberg Academic Hospital. It serves like 4 million of inhabitants of Soweto. And as the only trauma center, it's a massive hospital. It has around 4,000 beds. Nobody really knows how many beds it has because this is how it can look like on a typical Friday night. This is not the resus room. It's the floor outside of the resus room where major trauma patients are waiting to be seen and to get into the resus room. And this is a patient I was taking care of. He was having a couple of drinks with his friends and for like no reason they started a fight and they were beating him with bricks. And he came into my trauma unit. We were taking typical neuro trauma care for him. We sedated him. The CT scan didn't show much, actually. No hematoma to be evacuated. But the situation for this patient got worse. We called neurosurgery, and neurosurgery had to tell me they are overwhelmed. They cannot see the patient within 12 hours, and they will not be able to operate on this patient within 24 hours. This was actually quite frustrating for us reaching the end of the algorithm for this patient in this night. And it motivated us to go back, review the guidelines, what can actually be done to control ICP in those patients. Not many measures actually are there to control ICP in those patients. It's things you do in your neurocritical care units. It's sedation, minimal handling. We do head elevation, of course. Hypertonic saline can be done, but the only real surgical intervention to lower ICP in those patients is decompressive craniectomy, which is the gold standard to decrease ICP. But this gold standard comes at a price, as we know, and as we learned from the Rescue ICP trial. The Rescue ICP trial is fantastically done, and this figure shows quite nicely how the functional outcomes of those patients were. So to remind you, Rescue ICP randomized patients into medical management or decompressive craniectomy plus medical management. And as we can see here, we do have less mortalities in the surgical group, but those additional survivors, they are dispersed over the whole spectrum of functional neurological outcome. And as we also know from the evidence, some of those outcomes would not be acceptable to our patients if we have the chance to ask them. The healthy patients are asked, what is the functional outcome you would expect, what would be acceptable, which quality of life? Most of them say something like upper severe disability, lower moderate disability. This is their threshold. Why is that? Decompressive craniectomy is quite more procedure in itself. The pressure in the head is decompressed rapidly, and it has quite some complications, as you can see here. So we went back to pathophysiology. What else can be done for those patients? And the classical teaching and understanding of pathophysiology, it quite focuses on the arterial side of perfusion. It focuses on the pressures, but this fails to explain the importance of volume flow to the brain. And a more nuanced understanding of pathophysiology also includes compartments of your body, like the thoracic compartment, the abdominal compartment, and how those pressures are interacting with each other. Classic ATRS teaching, as you can see here, volume pressure correlation, once the mechanisms of compensations are outstretched, very small increments of volume can give us a big increment in intracranial pressure and decrease flow to the brain. So we did focus more on the venous side in our research, and this is probably something most of you spinal surgeons have experienced if you were operating on a patient laying on his chest, and if this pillow is under the belly, you will see a lot of back bleeding when you're operating on them. And this is probably due to another venous system, which is the vertebral venous system. It's a valveless venous system connecting your intra-abdominal pressure, your intrathoracic pressure to the brain. And we thought there might be something which is of interest and which can benefit our critically ill neurotrauma patients. And we did find those pretty old, actually 20-year-old reports from Professor Scalia from shock trauma in Baltimore. Professor Viviano, you also already pointed out to this publication, and I would like to go into some more detail here. So it's not a big case series. Actually, they included 17 patients who had decompressive laparotomies. Those patients all failed medical management, and they tried decompressive laparotomy in those patients. We can see here intracranial pressure before and after decompression. Quite a sick trauma population, ICP of 30 before they decompressed the patients. And after laparotomy, ICP fell to 17. And we thought this must have been connected to the intrathoracic pressure. And this connects via the central venous pressure to the brain. But as we can see here, decompressive laparotomy didn't really change much in the central venous pressure. So there must be some other pathway how intra-abdominal pressure is connected to intracranial pressure. And we think that the vertebral venous system might play an important role in this situation. This is a slide I got from Professor Scalea's talks, and here he showed us the effect again of decompressive laparotomy on ICP. And he also analyzed this for the sequence of decompression, because some of those patients had laparotomy first, some of those patients had craniectomy first. And as you can see here, and we will discuss this later with our preliminary data on those patients, on our patients in our cohort, decompressive craniectomy gives a bigger effect to ICP, but sequence doesn't matter much in which order you do decompression first, laparotomy or craniectomy first. And here we can see how the pressures did fall after laparotomy in those patients. And this is actually what got us started with our study idea back in 2018, the SCALPEL trial. We designed it as a multi-center randomized trial to study the intervention of decompressive laparotomy versus craniectomy. We plan to enroll 20 patients first, to do an interim analysis as discussed with the ethics monitoring board, and then enroll another 80 patients in this study. To be enrolled in the trial, we need to make sure good, high quality medical management is done first. And if you are familiar with rescue ICP, you will find those measures quite familiar, because we want to have the cohorts as close as possible in order to compare them well with them. So we need the patients to have head elevation first 30 to 45 degrees. Sedation must be adequate, ventilation, analgesia, all those things need to be done first. And patients will need an invasive monitoring. And if ICP is above 20 after those measures are done, the patient goes into step 2. And step 2, those are the more discussed measures for ICP control. They are not mandatory, okay? SCALPEL is a pragmatic trial, so the centers are welcome to do what they're doing best. Their local protocol is done. So if the local protocol uses ventriculostomy, they can do so. If they use mannitol, hypertonic saline, they can do so. And if after those measures are done, and the patient still has an ICP of above 20 millimeters of mercury for 1 to 12 hours, patient goes into step 3, which is check for eligibility, and we have a consent process which needs to be done with the patient or a proxy. In those situations, it will be a proxy first and the patient later. And then the patient can be randomized into the craniectomy or laparotomy. Our primary outcome measure is functional outcome measured by the Glasgow outcome scale, 12 months post-injury. It's the same endpoint as rescue ICPs, for example. Let's discuss inclusion and exclusion criteria here a bit. Our patients are between 18 and 65 years of age. And this is, again, very similar to rescue ICP. They need to have a CT scan, which shows abnormalities, of course, and they need to have an invasive ICP monitor in place. And ICP needs to stay above 20 for at least 1 hour of best medical management and not longer than 12 hours of best medical management. As you remember the DECRA trial, which didn't show benefit in patients who were having a decompressive craniectomy in a delayed fashion. Which patients are to be excluded? If the patient has bilateral fixed and dilated pupil, then they will be excluded because chances are quite high they will not have a good functional outcome. If the patient has a severe pre-existing disability, which will lead to a poor outcome, then this is something the local team has to decide based on the history of the patient. And we had those discussions already in Germany because our trauma population is aging, and we were screening a couple of geriatric patients if we want to include them into SCALPEL. Well, not like really geriatric, but they were like 60 years old and had already comorbidities, and so we didn't include those patients after some discussions. If the patient has intracranial injury which mandates for craniectomy, then the patient should not be included in the study, but we discussed this with Professor Krieg, and the evacuation of a hematoma, for example, is not considered an exclusion criteria if the patient is having a rise in ICP. After this, he can still be randomized into laparotomy or craniectomy group. And if the patient has an intra-abdominal injury mandating laparotomy, many of our trauma patients will have other injuries. If it's not an isolated head injury, and if we need to cut the abdomen for other causes, then they will not be included into SCALPEL. So where are we standing with the trial? We had some discussions around ethics, as you can imagine. And we have to do ethics with every study center. We cannot have ethic approval for all German centers. But the study has started now in Munich and in Berlin. The military medical center in Bonn, where I'm working, started to screen patients as well. We already saw some patients, but we were not able to include them because of exclusion criteria. But we used the decompressive laparotomy in combination with other injuries with traumatic brain injury patients. And I will discuss some results with you as well. Okay, and this list is not complete. Actually, within the next 6 months, we expect a couple of more centers to join us to screen patients and to enroll patients into the study. So how is this trial going? What are our first clinical experiences? It's a really, really difficult study to organize because it's not elective surgery. You cannot see those patients in daytime and have a study nurse who is doing this trial. Everyone who is doing on-call work in surgery, in neurosurgery, in trauma anesthesia, they will need to be informed about this trial, and they have to be briefed on a regular basis, and they have to enroll patients. That's a lot of discussions in a lot of centers, but we did see in the patients we already enrolled, which was 3 patients in the laparotomy group in Munich. They all had a pretty consistent effect on their ICP, which fell around 10 to 15 millimeters of mercury after the decompressive laparotomy was done. And other than Professor Scalea, we do not only include patients who have an increase in abdominal pressures, because we think that this mechanism also works in patients who have pretty normal intra-abdominal pressures. But as we all know, our trauma patients, even if they come with normal intra-abdominal pressures, it will not stay like this for a long time. If they are on critical care, if they get fluids, if they are ventilated with positive pressure, intra-abdominal pressure will go up, and we'll see effects on ICP due to this. What we also had to learn, this effect is not into place right after the laparotomy was done. If you do, as a neurosurgeon, the craniectomy, you will see the effects pretty rapidly. Laparotomy, it will take 60 minutes up to 120 minutes to hours to see the full effect of your procedure. Another thing we had to learn, and I can show you our SOPs, how we are doing the craniectomy, how we are doing the laparotomy, if you're interested in this. We are using another technique of open abdomen management, which is very safe, which is using negative pressure therapy intra-abdominally. And it includes like back dressings. Usually we use this for perforations and we leave the abdomen open. We put in those back dressings and put suction on those dressings. And if we have excessive abdominal dressings, the ICP is very sensitive and it will go up immediately. And if we remove those excessive dressings, we did see the effect to come down pretty rapidly again. So we have to be very carefully as general surgeons who are taking part of the study. We cannot go with our normal protocol using too much of those dressings. Okay, back again to the situation I was taking you with me in the beginning. So, as I said, we are doing the study in Germany, in my trauma center. We are doing it in Munich. But the population we had in mind to benefit was also patients like we see here in South Africa, who have not access to neurosurgery 24/7, who have limited resources maybe. And we hope that decompressive laparotomy can be a procedure which is benefiting those patients in the future. But it's still a long way with our trial. We need to improve our enrollment, and we have some ideas with new centers. But honestly, in Germany, we see less of those patients, and we're considering to have international centers on board with us in this trial, who have just more caseloads and to help us with this trial. Okay, and this is actually pretty much the end of the presentation. What I would like to show you is our SOPs, how we are doing those interventions. So, as I said, we are in the laparotomy group, we use negative pressure therapy because we know we have a very low risk of complications. This was really important during the ethics process. We had to show that the risk of hernia is low and the risk of fistulas is low, which can usually be achieved with those therapies. And we try to close the abdomen within 7 days, if possible, during multiple changes of dressings in the OR during that time. And usually it's possible to close the abdomen of those patients without advanced measures. And on the other hand, you can see how we're taking care of the patients in the craniectomy. So they all have a big craniectomy. Cranioplasty is considered, and they will usually have cranioplasty after rehab. Okay, so those are the two interventions, and with that, I thank you for your attention, and I'm very open to the discussion and your questions.
Thank you so much, Dr. Colbert. I think this has been a great presentation of the actual study that is still going on. I think your discussion related how has been proposed for specific findings into the decrease of the ICP number is something that is pretty well established, and I think you have mentioned that it's going consistently with the data that you already have. And as you also discussed as an alternative for less resources areas where regularly there are not too much equipment, training, or even other aspects in order to fulfill requirements for doing decompressive craniectomies or other type of interventions. Put this into the general audience and agenda for interventions proposed for managing TBI patients in this type of setting. I don't know if there are specific questions now into the chat.
There are two questions.
Okay, there are two questions. The first one is laparotomy is done after craniotomy. What is the time between both? What do you do in decompressive laparotomy? I think part of this has been answered, but if you want to reinforce the concept, Dr. Colbert, can you go ahead to answer this specific question?
Yeah, of course. That's a very good question, and we discussed it a long time. So crossover between groups is allowed. It's a pragmatic trial. What we do is we do the decompressive laparotomy, and we keep the patient in the OR, at least if we are doing this in Munich, because in Munich you would have to take the patient out of the OR, go into an elevator, and go up to the neurocritical care unit, which is not optimal for a patient after this decompression. And so we monitor the patient for 1 hour doing minimal handling with his head elevated in the OR or close to the OR after the decompression. And if we do not see adequate fall of the ICP, the patient can have crossover right away. And we already had crossover, but not after 1 hour. We saw this after 12 hours. ICP fell from 30 to 20 and then went up to 25 or something, and then had additional craniectomy. So this is something which needs to be discussed in the future. Where is the place for laparotomy? In my opinion, it's not the patient with an ICP of 35 or 40. It's maybe this borderline patient, 25 millimeters of mercury, who will have a good outcome with laparotomy alone, or those very sick patients. In order to combine those two measures, this can be a good strategy as well, but we need to study it in the future.
Okay, perfect. And there is a second question that you also discussed briefly before is who can perform the procedure? You have been shown that regularly have been done by general and trauma surgeons. And there is a question if a neurosurgeon can perform the procedure. So you have any comment regarding?
Excuse me, if a neurosurgeon can do laparotomy?
Yeah, there is a question regarding who perform the procedure, if the trauma surgeon or a neurosurgeon.
No, it's way too difficult. Only general surgeons will be able to do it. No, of course not. Of course not. It is in a healthy trauma patient. It's an easy procedure. It can be difficult in patients who have pre-existing operations and adhesions. Then it can be difficult. But if we think about a healthy trauma patient without prior surgery, it can absolutely be done by a neurosurgeon who has maybe limited training in this. For example, as you can see, I'm in the German military. We do train the other way around general surgeons to perform craniectomies. And I think this is much, much, much harder. And all of us, the general surgeons, say, oh, we do not feel very comfortable doing craniectomies. But if we turn it around, yes, neurosurgeons will be able to open the abdomen.
Okay, and I just want to chase Dr. Colwell and make a specific point discussion briefly here. Just want to share again a couple of slides. So this is, I think, a classical patient. This is one of our patients where you have this multi-trauma and multi-compartment syndrome where you can perform simultaneously many of these procedures. Like in this case, we have a patient with thoracotomy, laparotomy, and also decompressive craniectomy simultaneously. And as you have mentioned, we regularly see that the ICP number can go down as you have been discussed. And now I think because you discussed that the study was formally the protocol was formally proposed in 2018. Then I remember, as I told you, in 2022 was presented at the International Neurotrauma Society meeting in Berlin, and now you are recruiting patients. But in between, there have been a couple of issues that, especially for integrating into the protocols of care, have been critically important. We just published this a couple of weeks ago. That is the international consensus for non-invasive ICP monitoring when invasive systems are not available in the care of TBI patients. We call that the iconic consensus. This brings something very important that what if this patient can have the possibility to not only have invasive ICP monitoring like happens in few parts of the world, but can have also non-invasive systems monitoring. So these are the systems in place. We can perform this since the emergency room, and the integration of optic nerve ultrasound, pupillometry, and in this case, we have also the non-invasive ICP waveform analyzer can be integrated into defining what to perform next, because we are talking that maybe can be very useful for areas that do not have too many resources. And what if I have a patient that have abnormal non-invasive ICP monitoring and the laparotomy can be an option for them? So this is just an example of one of the systems that allow us to understand the compliance, because now we have been very focused in the compliance issue other than the ICP number, understanding that maybe when the ICP number change is very late for the patient and for the brain tissue. So we have been focusing many of the devices in analyzing also the compliance aspect. So my question is, are you actually taking into account the waveform of the ICP or just the number? Because maybe it's something that for the future and for what is already discussed related these aspects of the multi-compartment syndrome can be something that will be of interest. So I just want to ask you, what do you think about the possibility of integrating non-invasive systems? And also if you are taking into consideration in the data analysis, the ICP waveform configuration for associated not only the ICP number, but also the compliance inside the school?
Absolutely, very good question. Thank you very much. As we were planning this study, the non-invasive systems were not up to the quality, and the evidence was not good enough to build a study protocol based on this. So we decided against. The German military has some years of experience with non-invasive systems, and they all failed in the past, but I'm very aware of those new developments, and they are looking very good, and I think that's an important path in the future. The ICP threshold of 20 millimeters of mercury was also discussed quite lively. I do not believe that a single ICP cutoff can be a good marker. So we say it's a pragmatic trial, and the local team has to decide if the patient fits into this SCALPEL protocol. And probably ICP waveform is a better way to do it in the future, but it's not state of the art in all the centers which we were looking at. And ICP was like a common thing in the centers we were looking at to enroll patients. And this is why we decided for ICP, knowing that it's not a perfect measure in those patients.
Okay, great. Thank you so much. I think this is a very important study. It's something that really can add an option, especially for patients that are in areas that do not have too many resources, and even as a secondary approach or third line therapy for centers that have all the resources, and in some way ICP cannot be controlled in the regular protocols that have been proposed for management. So again, thank you for presenting this update of the study, and hopefully you can finish all the recruitment as soon as possible. I remember that in the original protocol you have proposed like 10 centers in Germany that are going to be recruiting patients. And thank you also for the Asian Congress of Neurosurgeons in order to present this opportunity for a situation that is every day more common, and we have tons of patients around the world that require emergency management in order to save life and also decrease bad outcomes for these patients. So thanks for the invitation, Dr. Rai.
Thank you. Thank you very much, Prof. Rubiano, for those comments. We can take one or two questions from panelists. Yes, Dr. Libun Singh.
Yeah, thanks, Raja. Thanks, Prof, for a very nice lecture on your trial. I basically three basic questions. First is, why do you take 20 millimeter mercury as cutoff point, where the Brain Tumor Foundation for edition have now used 22 millimeter mercury as the cutoff point? My first question. My second question, Professor. What do you do to those who cross over in your final data analysis? Because this is, although it is named nicely as a pragmatic trial, but many people now have make mistake in the statistical analysis. Because would you now consider those are failure cases because you can't analyze the outcome if they are crossover? So I want to know, how do you going to perform your statistical analysis for those group? And my last question, Professor, have you ever considered using a negative chamber for both thoracic and abdomen, or abdomen alone, as they are more non-invasive and have been proven to improve the negative pressure without opening up or doing a laparotomy? Thank you, Professor.
Okay, very good and tough questions. Thank you very much, Professor. Let me start with the first one, ICP. So we had a discussion around this. We discussed 25, then we said, no, 25 is probably too high. 20 was used by Rescue ICP, which is the gold standard landmark trial, which we are comparing our cohort with. So this is why we decided for 20. But as you also said, it's a pragmatic trial. The local team is not forced to enroll the patient. If the patient has a spike of the ICP of 20, nobody's forced to enroll the patient. Okay, this is just one of the inclusion criteria, and the local team can still decide. And if they feel no, this is not a SCALPEL patient, they can wait. If it goes up to 22, then they can maybe have another opinion on this. And the third question is the crossover. Yeah, that's a very good point as well. We will see significant cohort in our trial which has crossover. And I do not consider this a failure. Maybe this is just another treatment option. Maybe combining those two therapies has additional benefit. We want to enroll 100 patients, but it's still a pilot study. So we will, if we have it as a free arm study, we see laparotomy alone, craniectomy alone, and crossover. It will not be sufficiently powered. It's still hypothesis generating. Yeah, but we also calculated this as a superiority trial, and it was 4-digit numbers, 1,500 patients or something like this. It's absolutely unrealistic in our setting to finalize this. So we will have statistic flaws in the end. It's just the way it is. It's a quite rare disease, and it's hard to enroll those patients.
How about using negative pressure chamber, Professor, as alternative?
Oh yeah, very good question. This was asked by the ethics monitoring board as well. You're talking about the iron lung, right? This is what you're not talking about a hypobaric chamber, like a diving chamber. You're talking about the iron lung, right?
Yes, yes.
We do not have access to this anymore. It's nothing you can find in Germany other than in museums. Yeah, so they're just not manufactured anymore. I think the last patients who were living in this from the polio pandemic died a couple of years ago. It's not used anymore in Germany. It's an interesting idea, but it's just not available.
Thank you, Professor.
Thank you. Yes, Dr. Shahzad.
Yes, thank you for that talk, Dr. Benny. My question is, do you also do imaging for these patients? Because it will be interesting to see CT heads of these patients pre-laparotomy and post-laparotomy.
Yes, very good question. Pre-laparotomy, we will have a CT scan, which is part of the inclusion criteria. And as they are all managed in German university hospitals, they will have follow-up CT scans as part of the local protocol. But we did not put it into the protocol at a certain point of time, because we didn't want to interfere with the local protocol. Some hospitals, they take them to the scanner after 6 hours. Some do it a little bit later, and we wanted to leave this open to them.
So I'll just ask one more question, that any evacuable lesions in the brain were excluded from this study, if I am right. Is it?
No, we are looking at patients with diffuse traumatic brain injuries.
Only diffuse traumatic brain injuries are included.
Yes, but we decided if the patient had a hematoma, which was evacuated, and they are swelling later and having a rise in ICP, then they can still be randomized. But of course, you cannot have a patient with an epidural hematoma and do a laparotomy in him. They need neurosurgical treatment.
I understand. Well, anyways, thank you very much. So we indeed had a wonderful learning session, and it's of course novel, and we're looking ahead for the results. We'll look forward to next year for you to present your results in the same event. I'm looking forward to that. So thank you very much, Prof. Benny Colwell and Prof. Andres Urbano for taking out your time and support for the ACNS webinars. I would like to mention that this is being broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 760 people who are live from different channels from all around the world. We are extremely grateful to Prof. Shubin for that. Now we'll move on to the second session. So I'll hand this podium over to Dr. Shahzad Zamim for his introduction and invite the second speaker. Over to you, Professor Shahzad.
Thank you, Dr. Raj. Our next talk is about molecular strategies in the management of gliomas. And we all know how in the recent past, molecular strategies have completely changed the way we see these gliomas, not only see them, but how we classify them, how we diagnose them, and how we treat them. And a lot of interest have gone into it, and the future looks very bright on how our years of treatment for these tumors will now change now as we get better understanding of molecular strategies. Our next speaker is going to talk about exactly that. And our speaker is Hui Jiang, who's a doctor of medicine, and his researches are mainly on molecular diagnosis and precision treatment of gliomas. He has published more than 20 papers as a first or corresponding author in famous journals such as Cellular and Molecular Immunology, Neuro-Oncology, and Journal of Neurosurgery with the H-index of 17. He has hosted and participated in 3 National Natural Science Foundation projects and co-edited a book titled CNS Lymphoma. So, Dr. Jiang, over to you, please.
Respected experts, professors, and dear colleagues, I'm Jiang Hui from PK University Third Hospital, and I'm really honored to have this chance to talk about the surgical strategies for glioma with all of you today. It is the first day of the Chinese New Year, and we are still celebrating the Spring Festival here in China. So first of all, I would like to wish everyone a very happy new year. And the topic I will be sharing with you today is molecular biomarker-based surgical strategy for gliomas. As we all know, glioma are the most common primary malignant brain tumors. They can develop in any part of the intracranial regions and encompass a wide range of pathological subtypes. With glioblastoma accounting for more than half of all cases, glioblastoma in particular is one of the most devastating type of tumor, categorized by an extremely poor prognosis with a median survival of less than 2 years. Until now, the surgical resection remains the first and the most critical step in the treatment of glioma. Over the past decades, numerous neurosurgical pioneers have devoted themselves to advancing surgical techniques for glioma management. Alongside with these efforts, various auxiliary techniques such as had been developed, including intraoperative ultrasound and subcortical electrical stimulation, and neural navigation and fluorescent guides techniques. All these innovations have significantly enhanced our ability to achieve safe and more effective tumor resection. But glioma surgery differs significantly from that of other tumors, as it requires a delicate balance between the maximal tumor resection and preserving the patient's neurosurgical function. While more extensive resection reduces the residual tumor volume, it also increases the risk of the functional impairment. So therefore, our ongoing challenge is to find the optimal balance between these two critical objectives. The surgical strategy for gliomas had come a long ways over the years. We have moved from aiming for gross total resection to pursuing supratotal resection, robotic lobectomy, and even hemispherectomy. Date back to in 1928, Professor Danny published an article in the JAMA journal Well, he pointed out something quite sobering. He said that even if you performed a hemispherectomy for a small glioma, just a few centimeters in the size, it wouldn't kill the tumor. Recurrence was inevitable. This was a harsh reality that cast a shadow over the role of surgery in glioma. Since 2016, glioma have gradually entered the area of molecular diagnosis, and molecular markers such as chromosome 1p19q codeletion and IDH mutations plays a very important role in the diagnosis, treatment, and the prognosis estimation of glioma. Traditional morphological pathology is gradually transitioning from to the area of molecular pathology. This shift is also quietly influenced how we approach surgical resection strategy for gliomas. So with the rise of precision medicine and its establishment of molecular pathological classification for gliomas, we have started paying more attention to how molecular biomarkers can influence our surgical strategy. This had led to the development of the idea of molecular-based resections. A study from Europe suggested that for gliomas with 1p19q codeletion, the extent of surgical resection doesn't have a significant impact on patient outcomes. This could be because oligodendral gliomas are less malignant and respond well to the chemotherapy or radiotherapy. On the other hand, for patients with IDH mutations, the degree of tumor resection has the biggest impact on prognosis. This more extensive resection, the better the outcomes. So the research recommend a more aggressive surgical approach for IDH mutant gliomas. A study from a research team in Germany found that patients who had a gross total resection during treatment lived significantly longer compared to those who didn't receive the gross total resection. The benefit of gross total resection was seen in both IDH mutation and IDH wild type gliomas. But interestingly, there was no survival benefit in patients that with oligodendral gliomas. As for the repeat resections, they found that IDH wild type tumors showed a positive survival trend when more than 2 resections. Similarly, a study published in the Journal of Neuro-Oncology suggested that in IDH mutated astrocytomas, post-operative radial volumes have a negative impact on overall survival. However, in oligodendral gliomas, it seems that a small radial tumor doesn't have a strong impact on the overall survival compared to what we see in the IDH mutated astrocytoma. After performing a subgroup analysis, the authors found that even radial tumors smaller than 0.1 cubic centimeters can still affect the prognosis of IDH mutated patients, which highlights how crucial gross total resection is for treating IDH mutated glioma. Our teams had also done some jobs in the field. As we all know, the abnormality region of high-grade gliomas in FLAIR image is relatively large, and it includes both the area of the solid neoplasm and the regions of tumor cells infiltration. So we divide the patient into two subgroups, namely proliferation predominant high-grade gliomas and diffusion dominant high-grade gliomas. Patients who with a large enhancement region but a very smaller edema are defined as the proliferation dominant high-grade gliomas, while those with a smaller enhancement region but had a large edema that was defined as the diffusion dominant high-grade gliomas. After the survival analysis, we can see patients with proliferation dominant high-grade gliomas can benefit from the extensive resection of the flower abnormality region. We can see the p-value was reached the statistical significance. As for the IDH mutation state had also played a vital role in making the resection strategy. We found that the IDH mutated high-grade gliomas can benefit from the extensive resection of flower abnormality regions. We can see the p-value was less than the p-value was significant. While this survival advantage was limited in those with IDH wild type high-grade gliomas. When discussing the extended resection of gliomas, we must mention the Professor Dufo, who was the first to propose the concept of the supratotal resection. Traditional resection, gross total resection, refers to the removing of the tumor's contrast-enhanced lesions. As shown in the left picture, we can see the contrast enhancement lesion had been totally resected, but the flower abnormal signal area surrounding the tumors remains. In contrast, the supratotal resection requires the removal of the both contrast enhancing lesion and the flower abnormal signal areas, as illustrated in the right picture. We can see both the enhancement lesion and the flower abnormality regions had both be resected. A study from the MD Anderson in United States shows that the patient could achieve a significant survival benefit from the additional removal of the portion of flower abnormality region. The greater extent of resection, the better patient outcomes. And they also do the further analysis, and their results showed that the resection of 53.21% of the surrounding flower abnormality beyond the contrast enhancing resection was associated with significant prolongation of survival, compared with that following the less extensive resection. So, accordingly, it also states that when safely feasible, we should do more better than the gross total resection. Okay, considering the importance of the molecular biomarkers in the formulating the surgical resection strategy for gliomas, there is an urgent need for us to accurately predict the molecular biomarker status of a patient tumor before we do the operation. In recent years, we have been discussing the T2 flare mismatch, which was identified in 2017 as a valuable marker for predicting IDH mutation status. Its diagnostic criteria including high signal intensity on T2 weighted image and low signal intensity on FLAIR image with a peripheral ring of high signal intensity. The left picture is a typical image showing patient who has a T2 FLAIR mismatch. To meet the first criterion, the tumor should demonstrate striking, diffuse, and almost homogeneous high signal on T2 weighted image, with only subtle or very small region of internal hyperintensity permit, and a significant internal signal hyperintensity and heterogeneous on the T2 weighted images failed to meet this the first criterion. So we can see there was a 49 years old male with oligodendron IDH mutated and 1p19q deleted without the T2 FLAIR mismatch sign. For the second criterion, by far, the majority of the tumor should demonstrate hyperintense signal on the FLAIR relative to T2 weighted image, although the degree of the FLAIR signal separation may be inhomogeneous within the tumor. Crucially, a smaller intratumoral region of high signal on T2 weighted image and corresponding low signal on FLAIR as seen within intratumoral cyst and necrosis core should not be confused with the criteria of T2 FLAIR mismatch. We can say there is a necrosis on this image. So this was not this patient was not we can define it as a T2 FLAIR mismatch. Glioma with contrast enhancement often didn't meet the strict criteria for the T2 FLAIR mismatch sign. But however, in some cases with mild enhancement, we can say this is a mild enhancement. The T2 FLAIR mismatch sign may still be applicable. We can say there was a slight enhancement in this tumor, and after the pathology diagnosis, this patient was confirmed as IDH mutant glioma. According to the literature, the T2 FLAIR mismatch has extremely high specificity for diagnosis in IDH mutation, nearly researching 100%. However, its sensitivity is very low, and its occurrence rate is also quite low, around 10%. Additionally, it's not applicable to high-grade gliomas because we all know the high-grade gliomas often with obvious enhancements on the image. So which all this conditional limits is limited is clinical uniformness. So is there any image biomarkers with a high occurrence rate as well as good specificity and sensitivity that can predict IDH mutation status? So through the extensive review of the image data, we have identified a marker. We call it a counting sign. We call it the counting sign. Its definition of the counting sign is that non-enhancement tumor infiltration in the cerebral cortex We can say in the contrast enhancement T1 weighted image, the presence of hyper-intense of signal without a contrast enhancement. In the T2 weighted image, this should the presence of a hyper-intense signal completely envelop a cortical gray matter beyond the enhancing signal borders. This sign provides a valuable tool for predicting IDH mutation status and has a very high occurrence rate than T2 frame mismatch sign. The definition of counting sign emphasized the following. First, the lesion must involves the cortex, and the second, it is a non-enhancing lesion involves the cortex. We can say the non-enhancing lesion involves the cortex in this picture. But we can say in this picture, we can see it was the enhancing lesion involved the context. So this patient was defined as without the counting sign. The counting sign was negative in this patient. Okay, when both enhancing and non-enhancing lesions involve the context, we can say there is a enhancing lesion involve the context, and also some non-enhancing lesion involve the context. When this situation occurs, the counting sign should not be excluded. So the patient with both enhancing and non-enhancing lesions involve the context, we should define it as a positive counting sign. When the enhancing signal border approach the cortical surface, it is locally regarded as the enhancing signal completely envelop the cortical gray matter. This finding doesn't represent counting sign. Well, we can see this is the enhancing signal completely envelop the cortical gray matter. So the patient was defined as a negative counting sign. And in the left picture, we can see there was a non-enhancing lesion involved the gray matter. So the patient was defined as a counting sign, positive counting sign. When the vascular edema signal, just like the finger-like edema, involves the cortex, the counting sign should not be diagnosed. Because in sometimes the high-grade gliomas always concurrent with obvious finger-like edema, but the edema cannot be defined as the counting sign positive. So if the tumor with the finger-like edema involved the gray matters, in these cases we can't regard this tumor was a positive counting sign. Collectively, these are the diagnostic criteria for the counting sign that we have developed. It includes restricted criteria and auxiliary criteria for a total of 6 items. To this end, we conducted a clinical study. That the study of subject was developed into a training set and a validation set. The training set was from Beijing Tiantan Hospital, and with the inclusion criteria including the completed complete pathological and molecular testing data, as well as the complete MRI data, including T1 weighted image file, T2, and contrast enhanced T1 images. The validation set was from UCSF. So a comparative analysis was conducted to assess the advantages and disadvantages of T2 file mismatch and the counting sign in predicting IDH mutation status. In the training set, included a total of 526 samples, in which the incidence of counting sign in IDH mutant and 1p19 co-deleted glioma was 91.2% and 89.2%, and 23.4% in IDH wild type gliomas. While in the validation set, including a total of 501 samples, in which the incidence of counting sign in IDH mutated and 1p19q co-deleted gliomas was 92.3% and 84.4% in IDH mutated gliomas, and 14.6 in IDH mutant wild type gliomas. And in the following analysis, we found that the sensitivity and the negative predictive value MPV of the counting sign was superior to those of the T2 file mismatch. When with the advantage being more pronounced in the enhancing gliomas, we can see in the contrast enhanced gliomas, the advantage of counting sign will be more obvious than the T2 file mismatch. And a similar conclusion was also confirmed in the validation set data. The counting sign demonstrates greater sensitivity than the T2 file mismatch sign and can effectively predict the IDH mutation status in the contrast enhanced gliomas. So the T2 file mismatch sign exhibited a higher specificity and positive predictive value (PPV), but this value significantly decreased in the enhancing gliomas, while the counting sign showed higher sensitivity and negative predictive value, and these values didn't decrease in enhanced gliomas. From another perspective, we can think the two biomarkers, including counting sign and the T2 file mismatch sign, can complement each other's strengths. So in the multivariate analysis result, the final result shows that the patient age and the tumor enhancement and the counting sign can serve as independent factors for predicting IDH mutation status. Subsequently, we developed a mathematical prediction model based on these parameters. We can see that in the model A, accurately predict the IDH status in 458 out of 1,501 gliomas, with a significantly higher AUC than the model B. And the model C, on the other hand, the correctly classified IDH mutational status in for 46 out of 100 gliomas, achieving an AUC of almost 1, and the sensitivity of 92.2%, and the specificity of 88.2%. The decision tree, we can see the decision tree model predicted IDH status in 463 out of 501 gliomas, showing a slightly lower AUC and sensitivity, but higher specificity and F1 score. That's all. Thank you all for your attention. And I would also like to express my gratitude to Professor Xu Bin for the invitation, and to the organizing committee for giving me this valuable learning opportunity. Thank you, everyone. Thank you.
Thank you, Dr. Jiang. So first of all, congratulations on a very, very good study. I really liked how you first described the current status of the extent of dissections for gliomas and their outcomes, and how you explained the T2 flare mismatch before coming to your own a proposal of using the Contine sign to positively predict the IH mutant gliomas in over 90% patients. And as much as I foresee this as one way to go forward in picking out these patients beforehand, so these can be subjected to more aggressive surgical treatments as you rightly proposed, I would like to ask you, have you also tried correlating this Contine sign with other less sensitive markers of IDH mutation?
Can you speak slowly? I beg your pardon your question.
So one way to look at IDH markers is, of course, on radiology, but are you also looking at others other than radiology factors which can predict IDH mutation in these patients on top of the Contine sign? So, for example, the age of the patient, the location of the glioma. We know that IDH mutant gliomas tend to be at different cortical locations than regular gliomas, or other things.
In some cases, maybe sometimes the patient will concurrent with Contine sign and T2 flare mismatch sign. But I think the two radiological biomarkers can complete with each other in our clinical practice. Perhaps we can do more jobs to solve this. Some other image biomarkers to predict the state of IDH mutation, and even other such as 1p19q codeletion. That's all.
Thank you. And other than IDH mutation, was the Contine sign also useful in predicting 1p19q deletions or other molecular findings? Or did you only just study the IDH1 status?
I do some other jobs in predicting the 1p19q codeletion, such as the biomarkers of calcification. We can see we can see some cases with calcification in the CT scan image, and we found the calcification could be served as a image biomarker to predict 1p19q codeletion.
Yes. And was calcification also a factor in IDH1 mutation? Because we know that secondary gliomas compared to primary gliomas have different ratio of calcification, necrosis or calcification.
What?
So was calcification or necrosis also a factor in? I'm sorry, I'm not able to explain myself completely, and I understand your frustration. But calcifications and necrosis, were these also a factor in predicting IDH mutation in your series of patients?
Yes, the calcification could also be a imaging biomarker that can be used to predict IDH mutation. We have published another paper in the European Radiology that was committed to discuss this question.
So the reason why I'm asking is again referring to my first question is as an independent predictor, the Contine sign is more than 90% sensitive. But if we can combine this with these other predictors, does the sensitivity get any better?
Yes, yes. If we combine the several markers such as Contine sign, calcification, and other T2 mismatch sign, we can have a more pronounced, we can increase the predictive value of the biomarkers. But it will be sometimes if we included the more image biomarkers in the clinical practice, maybe maybe there will be some difficult problems to be solved. So we just want to perhaps we wish we could find a easy way to solve this problem. So we have found the Contine sign that can be used as another biomarker that can be used to predict the IDH mutation, especially for those tumors with contrast enhancement. As we all know, the T2 mismatch can be has its advantage in predicting the IDH mutation just in those tumors without contrast enhancement. So if we have the Contine sign and the T2 mismatch sign, that I think we can solve this problem better in the future.
Definitely. Thank you. So shall
Thank
we now
you.
open the questions for the panelists and the audience?
But I think there are none so far. I think so. We can hear your expert concluding remarks, Prof. Shahzad.
So firstly, I'm very excited at the prospect of this sign. And Professor Jiang has studied this on a very large cohort of patients. I mean, more than 500 patients in the training set and more than 500 patients in the validation set. And I personally, I see this as just one piece of the jigsaw, which when combined with other pieces, can lead us to identify with more certainty these small group of patients which have a much better outcome with aggressive surgery and treatment.
Thank you very much. So we'll come to the end of this webinar, and we are extremely grateful to Prof. Jiang Hai and Dr. Shahzad Shamim for taking up the time and support for the ACNS webinars. So I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both the speakers of today, Prof. Jiang Hai and Dr. Benny Colwell, as well as the chairs, Prof. Andres Rubiano and Dr. Shahzad Shamim, for the time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 760 people who have joined live on different channels. A special thanks to my co-host Vibhun Singh for joining me today. So until we all meet again online, it is bye-bye from all of us. Thank you very much for joining.